So search criteria, again, we looked at 10 years, clinical factors, thoracolumbar fracture outcome. Google Scholar resulted in 75. Refined, we got 53 articles. PubMed, 21. 42 after removing non-English articles and only including the humans. So risk factors analysis for predicting vertebral body recollapse after posterior instrumentation fusion in thoracolumbar burst fractures. This was a retrospective study from 2018, and they had two groups in which there was a recollapse, and then there was a well-maintained group. The independent predictors of recollapse after posterior instrumentation for thoracolumbar burst fractures were age at operation, which was surprisingly more than 43 years, and a preoperative body height loss of more than 54. But if you see that this study is coming out of Korea, and I'm so surprised that the age is 43. I don't know how they got 43 there. So even Irfan would be included in this study. Yeah, it's very serious there. Anyway, so which patients risk segmental kyphosis after short segment thoracolumbar fracture fixation with intermediate screws? So same thing that, this prospective data, only 43 patients and had AO type A3, A4, and B2 thoracolumbar burst fractures. Potential risk factors: smoking, habit, sex, age, neurological, and BMI. And what they found was obesity with BMI of more than 30 had increased risk of 1-year follow-up, like many, many, many studies that we know of. So this is, we know for sure that BMI, obesity is one of the risk factors so it's a radiological worsening afterwards, segmental kyphosis, not clinical outcome. Relationship between clinical outcome and spontaneous canal remodeling in thoracolumbar fractures. So the degree of reduction, so it was a prospective data from 2016 World Neurosurgery. They had only 38 patients who had posterior fixation, and factors potentially affecting the posterior postoperative degree of reduction. Spontaneous canal remodeling were age, location, degree of change of anterior vertebral compression ratio, fracture type, with retrobel pulse bone or not, presence of injury to the posterior longitudinal ligament, and posterior lateral complex fractures. So all these factors were, according to them, significant, but the problem was there was no statistically significant data, so it was only 38 patients in the study. So and they basically said that the vertebral body distraction can affect the degree of postoperative reduction and spontaneous bone remodeling. And these factors could correlate, but they had no evidence to show that. This is again a retrospective study from 2019, association between sagittal index, canal compromise, loss of vertebral body height, and severity of spinal cord injury in thoracolumbar burst fractures. And they showed that patients with sagittal index more than 20, with canal compromise more than 40, and loss of vertebral body height more than 50 are likely to have more severe neurological injury compared to others. So they could predict what kind of injury these patients would have. But generally, we all of us can if you have this scenario. In osteoporotic vertebral compression fractures with mild, moderate fracture severity at the single thoracolumbar level, the intervertebral cement volume of 4 to 6 milliliter could relieve pain rapidly. So looking at pain afterwards in osteoporotic fractures, the optimum vertebral fracture percent was 19.7, which could achieve satisfactory cement distribution. The increase of this vertebral fracture percentage, the incidence of cement leakage would also increase. But again, there is no there's only 130 patients divided, although prospective, but unable to come up with statistical significant outcome. Another retrospective, 153 patients, and they're looking at clinical radiological factors affecting progressive collapse of acute osteoporotic compression spinal fractures. So looking at specifically type A fractures. So they found a significant correlation between patient age, final height loss difference, and kyphotic angle differences. They were significant. Height loss and kyphotic angle difference were significantly correlated to type of fracture according to AO. The height loss difference was 18% in A1, 27% in A2, and 24% in type 3 type fractures, and 25 in A4 type fractures. Having said that, again, these were not statistically significant, this specific group. 3 months follow-up of conservative treatment for acute osteoporotic fractures, age, and AO spine classification were predictive factors for progressive collapse. And this was statistically significant for a specific age group. So factors affecting postural reduction in posterior surgery for thoracolumbar burst fractures. Again, this is from 2015. And this was postural reduction plays an important role in the reduction of kyphosis and compression deformity after thoracolumbar burst fractures. It was affected by delayed operation time, burst, split time type of injury, and severe anterior vertebral compression. So they were just looking at that at the time of surgery, postural reduction would work or not. So this was the specific thing they're looking at. Again, the number of patients not very low, not statistically significant. Supplementing posterior instrumentation was deemed necessary in 10% of cases following anterior recompression fusion. Age was the only significant factor that they found in this group. Looking at predictive factors for neurological improvement. So Asia grade at admission, fracture type, anatomical location of the injury, and preoperative neurological status, and the fracture type confirmed a positive predictive value. So these were predictive factors that have been shown by 2 studies, and both of them have shown that these had the predictive factors for neurological improvement afterwards. So depending on how severe your problem was, neurologically, radiologically, your outcome was like that. So it's understood that it has to be a true statement. So injury severity score and outcome of early stabilization, again, the damage control thing in polytrauma, 166 polytrauma patients, 2 groups according to injury to operation, and they looked at 4 groups according to injury severity score. So if the 2 groups according to the injury to operation, so shorter hospital stay, ICU, and ventilator days was significant. Patient with moderate to severe injury, ISS more than 26. Early stabilization showed shorter hospital stay, intensive care, and ventilator days than the patient with mild to moderate injury. Polytrauma patients whose fracture was stabilized with within 72 hours had better clinical outcome than those with late stabilization. Severely injured patients benefited more from early stabilization. So this was basically showing that obviously if you had operated early in moderate to severe injuries with early stabilization, you could improve outcome. And those polytrauma patients whose spine fractures were stabilized within 72 hours had better clinical outcome. The severely injured patients benefited more from early stabilization as well. So looking at increased sagittal vertical axis associated with less effective control of acute pain following vertebroplasty. So it was single level acute osteoporotic compression fracture. And they showed that vertebroplasty was more effective for acute pain control than conservative treatment, regardless of age, BMI, medical comorbidity, presence of previous fractures, pain duration, bone mineral density, degree of vertebral body compression, canal encroachment, and kyphotic Cobb angulation. So their thing was that if you did vertebroplasty, it was no matter what kind of problem you had improvement. And you had, it was less favorable if you had a problem with kyphosis. Unfortunately, again, this study did not have that many numbers to come up with statistical significance. So obesity, risk worsening of segmental kyphosis. There is level evidence 3. So, sorry, I'm just going to, these are the statements, and let me just put them as statements. How do you do this? Yeah. Segmental kyphosis following. Following surgery for thoracolumbar burst fracture. Actually, it's for all types of fractures, burst, osteoporotic, thoracolumbar burst fracture. Yes, no? Ahmed, shall we vote on this? Okay. Next. Increasing age, a factor to predict poor outcome in thoracolumbar burst fractures. And this is poor outcome meaning recollapse, poor outcome meaning neurological, poor outcome meaning multiple injuries. So they were all significant. But this more than 43 is interesting for me. I don't know. Increasing age is a risk factor. Oh, it's just a risk factor, is a factor to predict poor outcome in thoracolumbar fracture.
Okay.
Or just say full stop. So because we are voting on thoracolumbar burst fractures anyway. Okay, let's vote. And the third. And make that and small.
But that sentence is probably for osteoporotic fractures, isn't it?
This is for type A fractures, yeah, osteoporotic. And again, in old age. But they included all these patients. All patients are included. This is a Vaccaro group came up with this. You will have that poor outcome in any kind of disease you take. If you're taking high dose steroids or you're smoking.
Does it depend on the age?
No. This is we have age, we have already voted. Obviously it is. But smoking and you know age, old age you've already mentioned. But in comorbidities, we are talking about smoking and high dose steroids as poor outcome. We can vote on this. You can say
high dose steroid usage.
High dose steroids usage predicts poor outcome. Okay. It doesn't matter. You use high dose steroid, you become a risk. Okay, we change that to long-term high dose steroids. Let's go back first before we forget. So long-term. Yeah. We just leave it open. You can decide whatever long-term you want. No, but it's just to tell you that, yeah, these patients will have more problems, have poor outcomes. As long as, you can tell your patients that that's true. Yeah. So polytrauma, high injury severity score is not a contraindication to early surgery. Injury severity score. Yes? Or we can vote on the thing below. Early surgery is favored in polytrauma patients or high injury severity score. So you can say whichever way you want to say. So we put it in bracket. We have already said that less than 24 hours.
Instead of that, I would rather say polytrauma and high injury severity score should not be considered as a contraindication for early surgery.
Okay. Should not be. Yeah.
Considered.
Should not be contraindication to early surgery. That is fine. Let's vote on this.
As a contraindication. Should not be considered.
Should not be considered. Contraindication. A. Okay.
As a contraindication. As a contraindication.
Yeah, इसको सही करो. Okay. So that's done. Professor Hafid Bajamal is next.
Thank you.